Good morning, everybody. Today I'm going to be presenting on techniques for handling complex craniovertebral junction anomalies and how to avoid complications that can occur while performing this technique. So this unique masterpiece of the craniovertebral junction, which involves the occipito-atlantal joint and the atlantoaxial joint, is very, very beautifully organized because in one way it provides stability to the head. It allows the head to remain on its shoulders, and at the same time, it provides mobility at the atlantoaxial joint, thus allowing us to have a 360-degree view of the world around us. As long as the joints are functioning beautifully, there is no problem. But as long as there is some kind of instability, and the instability is most commonly occurring at the atlantoaxial joint. Occipito-atlantal joint is quite rare to be unstable, and most of the instability that occurs at the atlantoaxial joint. So when this joint malfunctions, it can cause a lot of myriad of neurological problems to the patient and can be risk to his life. So once the instability occurs, the best way to treat it is to perform a segmental atlantoaxial fixation. As you can see this image, this is the technique that was described by Professor Goyal in 1987, plate and screw fixation for atlantoaxial subluxation. It involves opening up of the joint, opening up of the C1, C2 joint, denuding the articular cartilage, stuffing of the joint with bone chips, and then performing the fixation by using direct application of screws to the atlas and axis. So you have a C1 lateral mass screw that goes into the facet of atlas and a C2 pedicle screw that goes into the C2. And this provides a solid fixation to the C1, C2 region. And this is an image showing the segmental fixation. As long as the fixation is done beautifully, then there is no problem. But as it is a complex region and the procedure is complex, there is a potential for a lot of complications to occur. And the best way to avoid these complications is to understand the anatomy and the biomechanics and the beauty of this region. So the main structures that are involved anatomically in this region that are to be noted is the vertebral artery. And you can see the course of the vertebral artery as it comes out of the transverse foramen of C2 and moves over laterally and superiorly to go over the posterior arch of atlas and then medial to the occipito-atlantal joint as it enters into the cranial cavity. So this is the most important structure that is at risk while performing an atlantoaxial fixation. The second thing that is to be noted is the presence of epidural venous plexus, vertebral venous plexus, and venous plexus around the occipito-atlantal joint and around the vertebral artery in this region. This is the second place that can cause a lot of venous bleeding, and it is essential to know how to control this bleeding with packing of appropriate amount of Surgicel and gel foam. And the third structure that comes in the picture here is the C2 ganglion. As you can see here, the C2 ganglion occupies the dorsal part of the C1, C2 joint. So cutting this ganglion gives a beautiful exposure of the C1, C2 joint. It is not necessary in all cases, especially in simple cases of atlantoaxial subluxation. You don't need to cut this joint or cut this ganglion, and you can just push it superiorly. However, in cases of basilar invagination, when the joint articulation is very high and there is difficulty in exposure, this technique of cutting the C2 ganglion, which was also described first by Professor Goyal, gives a beautiful window to the atlantoaxial joint and can assist in performing a great fixation. So let's look at the potential places for complications in this while performing this procedure. So this is one thing that you should begin with properly. Give the patient a proper position. The head high position helps in reducing the venous congestion. And this is a floating head position which protects the eyes. The traction stabilizes the head and also provides traction. The next structure that we are going to study is the vertebral artery. And this was an anatomical study that was published by us way back. So you see this anatomy of the vertebral artery. As I said earlier, it exits from the transverse foramen of C2. It curves superiorly and laterally, enters the transverse foramen of C1, curves over the posterior arch of atlas and then enters into the cranial cavity. So the places where the vertebral artery can get injured is in this region of the C2 pedicle while performing a C2 screw, and I will show you how. And also in this region when you're performing a C1 lateral mass, or if you do not perform a C1 lateral mass screw insertion properly, this is the other potential site of injury. This is in the normal situation. Otherwise, in the abnormal situation, there is also a potential for injury, and that is also something that you have to be aware of. So the vertebral artery, when you view it from the front, you see how it goes into the superior facet of C2. So this is the superior facet of C2, and the vertebral artery occupies the superior facet of C2, and that's why there is a chance of injury of the vertebral artery even in its normal course while performing a C1, C2 fixation. So basically, this was what was described by Dr. Goyal, that you divide this area, the C2 pedicle, into 9 quadrants. And if the screw insertion is performed in this medial and superior quadrant and then enters into the C2 pedicle, it is generally safe and avoids the vertebral artery. This was based on an anatomical study performed by us. So this medial and superior quadrant is the safest for C2 screw insertion, and the screw trajectory is directed superiorly and medially. So this avoids most of the vertebral artery related problems in a normal situation. This is just an image to show what happens when a vertebral artery injury occurs. Most of the times the injury may be tolerated well by the patient, but sometimes it is not. As you can see in this patient, the vertebral artery was having an abnormal course. A C1, C2 fixation was performed successfully with the reduction of the basilar invagination, but because of the vertebral artery injury, you can see the PCA infarcts, and this patient developed total blindness, and till date he is blind. He has improved in his quadriparesis, but he remains to be blind. This is another patient where the vertebral artery was in an abnormal situation, and again there was an injury during the procedure, and you can see the PCA infarcts. This patient also developed blindness after the procedure, but he recovered, and now he's pretty much recovered in his vision. But this, as you realize, that injury to the vertebral artery can have a potential of causing a lot of problems. So apart from the normal anatomy, where you pass the screw in the middle and superior quadrant, you have to understand the abnormal course of the vertebral artery that can occur. As you can see in these models that we have designed, you can see how the vertebral artery is entering here, medially into the cranial cavity. Here it is exactly on the C1, C2 joint and then entering the cranial cavity. Here there is the atlas is assimilated and the vertebral artery is running over the C2 pedicle and then entering into the cranial cavity. Here again, you can see that the vertebral artery is just at the lower border of the assimilated atlas at the inferior aspect of the C1 joint. And this is the vertebral artery coursing over. So inserting a screw here, dissection in this region can have the potential of causing vertebral artery injury. So we described the use of these 3D models that we use in complex craniovertebral junction surgery. And this helps us in planning the surgery, understanding the course of the vertebral artery, and thus avoiding an injury in this area. So this is just a 3D model showing you the vertebral artery course, which is lying here on the C1 lateral mass. So dissection in this region has to be done carefully. And once this is identified, you can appropriately dissect and then perform a C1, C2 fixation successfully. So this is one preoperative planning that we have, technique that we use to avoid complication of vertebral artery injury by studying the anatomy preoperatively very accurately. What happens when there is a high riding vertebral artery? So you see this region, this is the superior facet of C2, and the artery is absolutely impinging into the superior facet of C2. So you remove this thin bone in this area and you can see how deep it is indenting into the superior facet. In this situation, once you enter the C2 pedicle screw, there is a huge potential of causing injury as the screw will directly enter into the vertebral artery. So we've recently described this technique of mobilization of the vertebral artery, mobilizing it away from the superior facet of C2, so you can enter the C2 pedicle without any problem. So this is the technique that was described. As you can see here, this is the high riding vertebral artery in the region of the C2 superior facet. And by drilling this area of bone here and then drilling in this area and enlarging this area, you can effectively mobilize the vertebral artery laterally and then perform a screw insertion in this region. So I'm going to show you a small video that shows the procedure, not in detail, just shortly. So this is the patient. She was a 10-year-old girl and she had spastic quadriparesis. You can see the os odontoideum in this region, and you can see the atlantoaxial instability, which is reducing. And here you see the high riding vertebral artery. You can see this arrow that is showing the high riding vertebral artery in the superior facet of C2. So going on to the procedure. So this is just to orient you. This is the C2 spinous process. This is cranial, this is caudal, this is the left side, and this is the right side. So on the left side, a regular C1, C2 fixation was performed. The vertebral artery was not very high riding in this area, and a regular fixation could be performed. But as you will see, when I go on to the right side, sorry for that. So this is the screw fixation that is being performed on the left side successfully by doing a proper routine C1, C2 fixation. Now, as we move on to the right side, you will see this is the dissection on the C2 lamina. Here you can see the right C2 lamina, and you can see how the vertebral artery is occupying the vertebral artery foramen. This is the C1, C2 joint. So initially this area is drilled. The region of the pars interarticularis of C2 is drilled so that to make space for mobilization of the artery. Here you can see the vertebral artery in the vertebral artery foramen. This is the C1, C2 joint that is being exposed. We'll move further. So now you see this artery here. And this is the bone chip being inserted into the C1, C2 joint. This is the C1 screw insertion. In the facet of C1. And now you can see how our vertebral artery will be mobilized. So you see we had already drilled this area, and now the vertebral artery foramen will be enlarged so that the whole vertebral artery can be moved laterally. So now you have the whole vertebral artery under your control. And then after depressing the vertebral artery inferiorly, as you can see with this dissector, a screw is guided into the C2 pedicle. By mobilizing the vertebral artery inferiorly and laterally, you can see the drill hole being made, protecting the artery, and then a screw is inserted through this area. And you can see that the vertebral artery is completely pulsating here in its glory. And after depressing it, the C2 screw is inserted and the C1, C2 fixation is completed. And you can see the post-operative images showing the fixation. So this was recently published by us in neurosurgery. And these are some of the patients. I think you saw this patient. And here you can see the high riding vertebral artery. And here the vertebral artery is protected and the C2 screw is inserted after mobilizing it. This is another patient where the vertebral artery has been mobilized. So this is one technique of protecting the vertebral artery. What happens sometimes is if you're unable to do this, or the pedicle of C2 is broken, or there is a deficient C2 pedicle, then you remember this bone. So you see this beautiful C2 bone. This is the atypical C2 vertebra, where the superior and inferior facets are not in line as in the subaxial spine, but they have this, the C2 superior facet is anterior to C2 inferior facet, but the C2 inferior facet is also a mass of thick bone and can be used for inferior facet C2 screw insertion, as has also been described by us. So you can see this C2 screw that is going inferiorly, not into the C2 pedicle, but inferiorly. You can just limit it to the C2 facet, or you can include the C2-3 joint and make it a single screw passing through this region. So this is caudally directed inferior facetal and transfacetal screws for C1, C2 fixation. So you see this patient, she had a high riding vertebral artery. Somehow we were not able to mobilize the artery in this region, or for whatever reasons, maybe the pedicle was broken. A C2 screw was inserted into the inferior facet of C2. And you see this patient, you see the model in this region. There is an absolute deficiency of C2 pedicle on both the sides. And here you see the vertebral artery going into this with an abnormal course entering into the foramen region of the foramen magnum. And here we have used the C2 inferior facet, and this is one screw in the C1 lateral mass, and on both the sides, a C2 inferior facet screw was inserted. So that is another technique that can be used to avoid complications involving the vertebral artery. Another technique is atlantoaxial joint jamming. This was described by Dr. Goel in 2007, where you insert the spacers into the C1, C2 joint. We don't use this routinely, but if necessary, it can be used as a standalone technique for fixation. So you see this model here. You see the artery here on the lateral mass of C1. So on this side, a regular C1, C2 fixation was performed. On this side, where the artery was imminently in danger, just a spacer was inserted into the C1, C2 joint and the fixation was performed. So this is another technique that can be used in case of any difficulties for performing C1, C2 fixation. This is another technique that we have published recently in World Neurosurgery, transcranial insertion of atlas facetal screw. So sometimes what happens is the basilar invagination is quite severe and the joints are quite rostrally positioned. And it is very difficult to expose it from a posterior region. So what happens is, what we do is we perform a transcranial insertion of the C1 facet screw. A small craniectomy is made in the region of the just above the C2 pedicle and the C1 lateral mass, and an extradural exposure of the C1 facet is done. And the screw is then inserted from the occipital condyle inferiorly into the C1 lateral mass, thus providing a strong fixation. You can see another patient here. This is the high C1, C2 joint and transcranial small craniectomy in this region, and a transcranial insertion of the screw has been performed in this direct C1 fixation after the craniectomy was performed. This is another patient with a high basilar invagination, and you can see a transcranial screw insertion has been performed for the C1 lateral mass on one side. On the other side, transarticular screw fixation was performed, again because the joints were very high, and you can see the good reduction and fixation. Another technique that was described by Professor Goel is screw implantation at the spinolaminar junction, and that, if everything fails, can be used as a salvage technique for performing C1, C2 fixation. We don't use this nowadays, but this is one of the things you have in your armamentarium if all else fails. So this is a patient with an atlantoaxial instability and basilar invagination, and a spinolaminar junction screw fixation was performed. So basically, to end, generally occipitocervical fixation is not performed. We have truly abandoned this procedure, and most of the times we are successful in performing a C1, C2 fixation with all these previous techniques that I described earlier, and they avoid any complications in this region. But this is the last thing. Sometimes, if nothing else, then you can do occipital cervical fixation. But as you have seen in my presentation, we have completely abandoned it. So thank you very much.
Excellent presentation, Dr. Shah. Any questions? I think no wonder why you are having this experience, and you have explored all the options for vertebral artery preservation, as you have huge experience being in Makkah of a junction if there are no question, in the interest of time, I would take permission from my co-chair, Dr. Kulkarni, who has been leading this session, to close the session with thanks to all the speakers for their timely and very nice presentations. And I thank Professor Sahu and the organizing team for giving us the opportunity to run this session. Thank you.
Thank you, everybody. Thanks for attending.